Doctor, it's already 9 p.m., so we can start. Doctor, you are on mute, doctor.
1 minute. I am joining. 1 minute. Hello, good evening. Am I audible?
Yes, audible.
Yes, doctor.
Sir, how are you?
Fine.
From my side, I am ready, sir. Whenever you tell, we'll go ahead. No problem.
Is the Neeraj sir joined? Dr. Vishal sir? Dr. Vishal?
Hello.
Yes, Dr. Vishal.
Sir, I am unable to see anybody else other than both of us and probably one of the office bearer in this, because there is a panelist link and there is a separate link for viewers. I guess if there is office person from IAP, she can enlighten us. She was there recently.
Dr. Vishal, are you able to hear me?
Yes, doctor. Others have joined through the viewers link.
Yes, sir, you are audible.
Okay, thank you. So, who will start the session, sir?
Yes, no
Any
problem.
coordinator? Any coordinator for the session?
Sir, you are the coordinator.
I am the moderator of the session.
Okay. So probably you may have to start.
Only two of us are on screen.
Sir, others have joined through a different link. So probably we will not be able to
Okay.
see them. We'll not be able
Okay.
to see them. That's what I understand.
Yes, doctor. If they post
Okay.
questions, I will post it in the chat box.
Okay. And may I know your introduction, madam?
Doctor, I am from the DIAP team. I'm the technical host here.
And your good name, please?
Okay.
My name is Shweta.
Okay, okay. Thank you.
Ma'am, is there any panelist for the session?
So I don't know. Dr. Neeraj Awasthi might join. I have no idea.
Sir,
Okay.
only
So-
two of us. You are
Two
the
of us.
moderator and I am the speaker.
Okay.
You can start, doctor.
Okay, sir. Dr. Vishal, sir, I am introducing you. Okay. Good evening, everyone. Hello. Good evening, everyone. I welcome you all in DIP Pediatric Cardiology Chapter of IAP. Today is the session of what pediatricians should know. Today we have the speaker, Dr. Vishal Changla. He is a pediatric cardiologist at based at Ahmedabad. He is having experience of more than 13 years of practice in pediatric cardiology. He is also a good orator. Dr. Vishal, sir, over to you, sir. Please start session, sir.
Hello, everybody. Just give me a moment so that I can share my screen. Shweta madam? I am unable to see the option of screen sharing today. I don't know why. Do you have that option on your screen, Dr. Prabhat?
Share a screen.
Yes.
Yes, yes, there is there. In the
Where
middle
is?
of the bottom.
Yes.
Bottom
Yes.
of the middle line.
Yes. Yes. Fine. I got it.
Doctor, are you facing any issues?
Yes. Yes. My Apple laptop is asking permissions. Just bear with me.
Yeah.
Okay. So do you see my screen?
Yes, doctor, it's fine.
Yes.
Okay. So today we'll be discussing very important topic, OPD management of congenital heart disease, what pediatrician should know. Okay, so it is in a way very simple and easy topic if we understand the basic classification of congenital heart disease. We all know there is acyanotic congenital heart disease and cyanotic congenital heart disease, but there is one more subclassification which is very important for all of us to know and to plan further treatment action for a child with congenital heart disease. So clinical classification of congenital heart disease, if we look at the saturation, if saturation is more than 95, by and large, we call it acyanotic congenital heart disease. If saturation is less than 95, we call it as cyanotic congenital heart disease. And this rare exceptions like pink tetralogy also can have saturation more than 95, but we'll ignore those exceptions and we'll stick to basic classification. Now, in acyanotic CAD, there are shunt lesions and non-shunt lesions. Shunt lesion, we all know, ASD, VSD, PDA, epindow, LV2RA shunt. These are all shunt lesions, and non-shunt lesions can be valvular and non-valvular lesions. Valvular lesions like congenital aortic stenosis, pulmonary stenosis, congenital tricuspid regurgitations are non-shunt lesions. They are still acyanotic CHDs. Cyanotic CHDs, broad classification with reduced pulmonary blood flow and with increased pulmonary blood flow. Those with reduced pulmonary blood flow is usually a combination of large VSD and severe PS. It can be other associated malformations also, but usually it is large VSD or large ASD with severe pulmonary stenosis, which is like a TOF-like physiology, wherein we have symptoms of cyanotic spells. Those with increased pulmonary blood flow, if we look at echo report, there is a line, either there is no pulmonary stenosis or there is a PH. Both of them are synonymous. A child with cyanotic CHD without pulmonary stenosis has pulmonary hypertension, and that's why it is increased pulmonary blood flow. Our entire discussion for today's topic will revolve around this basic classification. Is there any question at this point, Shweta ma'am, so that I can answer? Otherwise, I will move forward. I guess no question at this point of time.
No question. Please go ahead, sir.
Now, we have to conclude on paper that what is our basic diagnosis. We can always conclude by saying, I will give certain examples, like acyanotic congenital heart disease, shunt lesion. Acyanotic congenital heart disease, non-shunt lesion. Additionally, we can write no cardiac symptoms. Cyanotic congenital heart disease with reduced pulmonary blood flow with cyanotic spells. Cyanotic congenital heart disease with increased pulmonary blood flow with congestive heart failure symptoms. So, depends on the entire clinical set of information, we can have a real bedside diagnosis which can help us in OPD management of such patients. So let me give an example. A newborn baby who is 7-day-old goes to a pediatrician for routine checkup, and pediatrician finds there is a systolic murmur, no other cardiac symptoms, normal pulses, normal saturation, everything is all right. So what do we conclude? What is our clinical diagnosis? Can anybody write in the chat box? Okay, so clinical diagnosis is acyanotic congenital heart disease, mostly shunt lesion, no cardiac symptoms, probably small shunt lesion. So what is the treatment? Yes, there is a requirement of elective echocardiogram, preferably by a pediatric cardiologist, and no treatment is required at this point of time. I'll give you another example. If there is a child who is 3-month-old with history of feeding difficulties, breathing difficulties, suppressed suck cycles, recurrent respiratory tract infection, 1 hospitalization for pneumonia, a slow weight gain, normal saturation. What is our clinical diagnosis? Very simple. And there is a presence of murmur, loud heart sound. So what is our clinical diagnosis? The clinical diagnosis is acyanotic congenital heart disease, increased pulmonary blood flow, large shunt lesion. So this is our, and with cardiac symptoms. So this is our clinical diagnosis. There is no need of echocardiogram for this diagnosis. Okay, again, a child who is 9-month-old with history of recurrent cyanotic spells, saturation of 65%, and there is cyanosis which is present in pan-digital clubbing, grade 1 clubbing. And if you examine the child, chest appears overall silent chest, silent in form of there are no precordial activities, normal first heart sound. If we look at closure, there is a single second heart sound and 3/6 early systolic murmur. Now, what is our clinical diagnosis? Our clinical diagnosis is cyanotic congenital heart disease with reduced pulmonary blood flow. So cyanotic CAD with reduced pulmonary blood flow is also known as tetralogy of Fallot-like physiology. Okay. So again, echocardiogram is not required. Basic clinical diagnosis is available to start further treatment. Obviously, we'll discuss treatment plan in subsequent slides. Last scenario, a patient who is 5-month-old with similar type of symptoms I have just described in a second case scenario, like suck rest, suck cycle, breathing difficulty, feeding difficulties, slow weight gain with low saturations, and there is some murmur present, systolic murmur. What is the clinical diagnosis? Clinical diagnosis is cyanotic congenital heart disease with increased pulmonary blood flow. So cyanotic CHDs with reduced pulmonary blood flow predominantly present with symptoms of cyanotic spells, low saturation, and usually heart failure symptoms are absent. While cyanotic CADs with increased pulmonary blood flow present with heart failure symptoms and cyanosis. While in acyanotic congenital heart disease, heart failure symptoms present only if there is a moderate or large shunt lesions. Small shunt lesions or non-shunt lesions usually do not present with heart failure. However, severe degree of valvular regurgitations, rheumatic heart diseases sometimes can present with heart failure. Chest X-ray, a very important bedside tool apart from clinical examination, history and SpO2. Chest X-ray, if we look at pulmonary plethora, endon vascular appearances of dilated pulmonary arterioles, tells us that we are dealing with situation of increased pulmonary blood flow. If we look at oligemic lung fields, relatively blackish lung fields, then we are dealing with situation of reduced pulmonary blood flow. And if we look at pulmonary vasculature, which is appearing normal, like let us say small to moderate size VSD, moderate size ASD, usually pulmonary vasculature is normal in such scenario. So we can say balanced circulation, neither decreased nor increased. So I am repeating and going little bit slowly as far as this clinical classification is concerned, because on the basis of this classification only, straight away we can start OPD management of CHD while awaiting detailed echo report and pediatric cardiac evaluation. Investigations, hemoglobin, very important. Child without heart disease or child without chronic pulmonary diseases, hemoglobin more than 10 is relatively okay. But when we deal with congenital heart diseases, especially if we talk about acyanotic CHDs, HB around 10 is also a significant anemia, and ideally they should have hemoglobin of 12 to 13 plus. Usually, or it is very good idea to add iron in all the prescriptions of congenital heart disease. There is no harm in it. Why am I saying urea, creatine, electrolytes? Two reasons. One, sometimes because of congestive heart failure or associated secondary illnesses like pneumonias, they are prone to hypovolemia, dehydration, and that's why pre-renal failure. And if it is unrecognized, then it goes into renal failure. We have seen many cases who are just referred for clinical evaluation, those who are referred after clinical evaluation and those who are referred for pediatric cardiac evaluation. We have seen we have diagnosed them with CHD, but when we do urea create electrolytes, sometimes urea create are abnormal, sometimes only urea is abnormal, because they have chronic breathing and feeding difficulties. Their oral intake is suboptimal and it causes renal compromise. TSH, we should have very low threshold because undiagnosed hypothyroidism associated with CHD can give rise to significant symptomatology. Let us talk about Downs with heavy canal defect and undiagnosed hypothyroidism. It is a very complicated situation, and these children are very symptomatic. VBG or ABG, again, two reasons. As I said, many of them present with congestive heart failure, not so sick enough that they are in a hospital, but still they have significant acidosis. So early recognition of acidosis and renal compromise can prevent significant complication and late PICU admissions. So after talking about such basic tests pertaining to management of CHD, I am moving further. However, those with CHD ideally should undergo screening by means of USG abdomen and USG cranium whenever anteofontanel is open to rule out other associated congenital malformations. Other test depends on the need. Now, in India, many times we face situation where pediatrician have ordered echo or have ordered pediatric cardiology consult an echo, but parents have not done it, or parents have run away, or they might have visited another pediatrician, or what we call doctor shopping. Why? Because there is a significant social stigma associated with congenital heart disease. And with my experience, I would request my fellow pediatricians to add certain points while ordering pediatric cardiac evaluation. First is, it is just a sonography of the heart, and it doesn't harm the body. The way we do USG abdomen, doctor will apply gel on the chest and will find out how your heart is, how your kid's heart is. Majority of the heart diseases are treatable and they live normal life like you and me. But timely diagnosis is important. If we miss the boat, then there can be a problem. So it is better to look at the heart of your child, and treatment is very much possible, and with majority of them have excellent prognosis. So taking them into confidence that, look, I am not suspecting something very serious which doesn't have treatment. I'm suspecting something, I want to confirm. When there's soft murmur in a happy, healthy child, many times you can even say that probably this murmur is an innocent murmur and echo will turn out to be normal, most likely. But I'm ordering it for our satisfaction and clarity for further treatment plan. So acting as if you have already diagnosed the condition and you are starting some basic management on the basis of clinical diagnosis will reassure family and reduce fear of so-called pediatric cardiac evaluation. Now, once you have echo report, what should a pediatrician look into? Now, first, who has done it? Whether it is done by a pediatric cardiologist or a cardiologist or radiologist, sometimes non-invasive cardiologists, sometimes physicians, self-trained or trained echocardiographers. So we should look at who has done the echocardiography. It depends on that. We can have further idea that how reliable is the diagnosis. whether there is associated conclusion. Like sometimes we see entire echo report, all the points, but there is no conclusion or final diagnosis, all the points and signature. Very often we see conclusion and summary. So it is good idea to read conclusion and summary first, and then you can go through echo reports. Sometimes echo reports are very short, sometimes they're long, 2-page, 3-page echo reports. We also should look at whether there is associated consultation. I'm sure Dr. Prabhat Kumar will agree with me that whenever a pediatric cardiologist sees a patient, does echocardiography, he or she always writes treatment plan, clinical diagnosis, final diagnosis, possible outcome, management plan, relative counseling, etc., etc. So it makes job of a pediatrician much easier. If we deal with acyanotic CAD and shunt lesion, we should look at whether shunt is small, moderate, or large. If just size is mentioned, then usually shunts less than 4 mm are small, 4 to 6, 7 mm are moderate, and more than 7, 8 mm are large. Look at the shunting pattern, whether it is left to right or right to left or bidirectional. Important, as we have seen earlier, that there is associated pulmonary stenosis or pulmonary hypertension. Cyanotic CHD with severe pulmonary stenosis, we are dealing with top physiology. Cyanotic CHD without pulmonary stenosis, we are dealing with pulmonary hypertension situation. Whether that word is written or not, PH word, it is different story. But if you do not look, if there is absence of word severe pulmonary stenosis and echocardiogram in a child with cyanotic CHD, it is severe PH until proved otherwise, at least for clinical management purpose. And acyanotic CHD shunt lesion should have associated diagnosis of no pH, mild pH, moderate pH, or severe pH. It is responsibility of an echocardiographer to mention that. So this is all about echo report. So no treatment when you feel that murmur can be innocent, when you feel that you are dealing with acyanotic CAD with small to moderate shunt lesions, no cardiac symptoms. When you feel that there is a cyanotic CHD, but child is completely asymptomatic, saturation around 85, still it is okay not to start anything. However, in cyanotic CAD scenario, even if they are normal with reduced pulmonary blood flow, we should start propranolol and iron. No treatment, when I say that, it doesn't require cardiac treatment in scenarios which I have mentioned. But if there are associated issues like bronchiolitis or malnutrition or vaccination issues, obviously pediatrician should attend as per the protocols. But as far as treatment is concerned, for cardiac treatment, the scenarios which I have mentioned doesn't need any treatment. Innocent murmur, small to moderate shunt lesion in acyanotic CAD, etc. Now, management of lesion with increased pulmonary blood flow. Remember, there are two situations where we see such patient. One, increased pulmonary blood flow with normal saturation. So, acyanotic CAD with increased pulmonary blood flow. Another is cyanotic CAD with increased pulmonary blood flow. Means cyanosis with signs of heart failure and increased pulmonary blood flow. Both the scenarios have similar treatment. Furosemide, spironolactone, enalapril, iron, digoxin. We have seen that usually pediatricians' prescription have digoxin in the treatment sheet, but majority of pediatric cardiologists write digoxin very rarely in a special situations like dilated cardiomyopathy or certain arrhythmias. Usual scenarios of CSDs, digoxin is usually missing in pediatric cardiologist prescription because there is no proven role of digoxin in cases of shunt related congestive heart failure. However, there is no as such contraindication. If you want to write, you can write. Nutritional management, very important because these patients, majority of them are nutritionally compromised, and optimize hemoglobin. Let us say if you see the child with increased pulmonary blood flow like symptoms, hemoglobin of 7, start on all this medicine, admit the patient, might as well give packed RBCs. Child with normal heart with HB7, obviously we don't transfuse. But child with a congestive heart failure, with hemoglobin 7, all these symptoms which I have mentioned, it is good idea to transfuse. Obviously, in a 2 separate aliquots of 7 to 10 mils per kilogram, 24 to 48 hours apart, along with peri-transfusion coverage of IV furosemide. So, please remember this medicine. I'm not mentioning dose because these are common medicine and almost all of them know about the dose. Furosemide and spironolactone, 1 milligram per kilogram per dose. BD, obviously start depends on the symptoms. You can even start with as small as 0.5 mg per kg per dose BD or OD. Sometimes alternate days. However, if there are significant symptoms, better to give twice a day. Enalapril, 0.1 mg per kg per day, twice a day. Digoxin, 10 microgram per kilogram per day in 2 divided dosages. If child is less than 10 kilogram, more than 10 kilogram, you can give once a day dosages. Nutritional management and optimize HB, as I said earlier. Management of the lesion with reduced pulmonary blood flow. Now, a child with cyanosis, with cyanotic spells or without cyanotic spells, but absence of congestive heart failure symptoms, until proved otherwise, we are dealing with situation of so-called large VSD, severe PS, TOF-like physiology. Give beta blocker propranolol 1 mg per kg per dose. BD, iron, avoid dehydration and optimize hemoglobin. Now, because dehydration can precipitate cyanotic spells, many times we see pediatricians restricting IV fluid while treating children with tetralogy of Fallot. We must not do that. In fact, 1.2 to 1.5 times of the IV fluid requirement we must give to such children. It will be beneficial for them and it will significantly reduce the chance of cyanotic spell. And if they are in cyanotic spell, give lots and lots and lots of fluid, as if you are dealing with a child with profuse diarrhea, severe dehydration and hypovolemic shock. Bombard them with IV fluid. It will definitely help them. So last maybe 5 minutes and then we can take question answers if there are any. Counseling, very important. We can say that if there is a small shunt lesion or a moderate shunt lesion, we can say that natural recovery is also possible. However, we know that certain defects can never close spontaneously. Let us say large malaligned VSTs with 50% aortic override or subpulmonic VSTs, gerbold defects. Such lesions have very, very minimal chance, or let us say hardly any chance of spontaneous closure. However, for initial counseling purpose, you can say that there is a chance of natural recovery in many of them. and surgery is not always required. And they live normal life like all of us. We expect normal life. Tetralogy of Fallot, TAPVCs, TGAs, these all live normal life like all of us. I'm not going into detail into this topic when there is a child in NICU and PICU and pediatrician is looking after, because topic for the day is OPD management. I just say that echo is a third eye for a neonatologist or a pediatric intensivist. And ideally, all ICU kids should undergo echo, but if there is no bedside echo facility, then whenever they are in shock or even slightest of doubt, they are on ventilator, high parameters, who knows, sometimes unexpected CADs are there, dilated cardiomyopathies. So, and it is just looking at the heart. Isn't it a good idea if you are aware about the cardiac condition and you are treating a child with significant hemodynamic compromise in PICU? So it is good idea. Echo is a third eye for an intensivist. Vaccination, apart from routine protocols, even we should offer optional vaccinations, especially those with increased pulmonary blood flow, because they are prone to pneumonias. So ideally, annual influenza virus vaccines. I'm sorry. So, sorry. So annual flu vaccines are helpful to them, which will give significant protection towards episodes of bronchiolitis and viral pneumonias and things like that. Now, very, very important slide, which is dear to me. Failure to thrive in a child with CHD. Remember, all kids with CHD doesn't develop failure to thrive because of CHD. We often see that even if child has a small 3 mm muscular VSD, but if this child has a failure to thrive, pediatrician explain them that this is failure to thrive because of congenital heart. So all CHDs doesn't produce failure to thrive. Please remember this. So usually those with increased pulmonary blood flow lesions have failure to thrive. So let us say a child with 5 mm ostium secundum ASD who is 5-month-old and not gaining weight appropriately. This ASD is not responsible for failure to thrive. We have to evaluate non-cardiac causes of failure to thrive in children with insignificant CHDs. Sometimes just echo report of CHD may blind us towards looking at other causes of failure to thrive. I have diagnosed at least in last 13 years, I have diagnosed at least more than 200 cases of renal tubular acidosis in children with CHDs. There are other in the list like celiac disease, thyroid issues, renal dysfunctions, chronic renal failure, malabsorption syndromes, and many. So we must look at non-cardiac cause of CHD in a child who has failure to thrive as well as some heart problem. Yes, we have to be careful for further evaluation and further management, but it is good idea if you have slightest doubt, child doesn't have failure to thrive, happy child, jumping child, and scenarios which I have mentioned, significant failure to thrive, in spite of proper nutritional management, we must dig into further non-cardiac evaluation. Remember, there is no age and weight criteria for pediatric cardiac intervention or surgery. In a current era, irrespective of age and weight, we can do interventions in cath lab or we can do open heart surgery. Let me give you an example. A newborn with severe coarctation of aorta, LV dysfunction, weighing just 1.2 kilogram, can successfully undergo balloon coarctoplasty, and we can allow child to grow and monitor further. A child who is 900 grams stuck on mechanical ventilator because of hemodynamically significant PDA, not responding to supportive management, paracetamol, indomethacin, ibuprofen, we can close it in cath lab without any significant morbidity. However, lower the weight, there is some risk involved in the procedure, but risk of not doing anything is 100% death, and risk of doing is small risk. So गया वो जमाना जब कहते थे कि बच्चा 10 किलो का हो जाएगा उसके बाद इसकी सर्जरी हो पाएगी, या तो 8 किलो के बाद. ऐसा कुछ नहीं है. Irrespective of age and weight, we can. Yes, if child needs it, it doesn't mean that a 1-year-old child with small muscular VSD should undergo intervention. But yes, if child has symptoms and child needs it, irrespective of age and weight, we can do it. Treatment modalities, I am not going into great detail, but just 2-3 sentences, that if there is a problem in the heart, we can treat with 2 broad treatment modalities. One is intervention in cath lab, where we do puncture in the femoral vein, sometimes in the axillary vessel or a internal jugular vessel. And these are pinhole procedures without scars, and they do well, less morbidity, less risk majority of the times. And those who are not amenable to cath lab procedures, we can do open heart surgeries while cutting open the chest. However, minimally invasive cardiac surgery is also possible in certain diseases, like we can make a smaller incision on xiphisternum, which is known as mini sternotomy, or a lateral thoracotomy, sometimes infraclavicular approach, inframammary approach, depends on the surgery. However, minimally invasive cardiac surgery is not option for all patients, but yes, those who are not amenable to cath lab intervention and disease is amenable to minimally invasive open heart surgery, we can always opt for it for various reasons, including cosmetic as well as less morbidity. Prognosis, I would just say, if timely treated, excellent in majority, barring children with chronic dilated cardiomyopathy or children with single ventricle physiologies. Most of them will live normal life like you and me. So all these points related to management and prognosis and treatment plan should be discussed while dealing with the family. Thank you very much for patience listening.
Thank you, sir. Thank you, Mr. Hal, sir, for your lucid presentation. I think Dr. Neeraj sir is in. Neeraj sir.
Hello, Dr. Prabhat. Hello.
Hi, sir. Good evening.
Good evening.
Good
Yeah.
evening. Over to you, sir.
Listening to Dr. Vishal with such a wonderful presentation. But Dr. Prabhat, you can continue with the moderation.
Sir, it's a very bad thing. Only 3 of us present in the meeting. And I think there is no comment in chat box.
No, actually,
So,
sir, the chat box will not show here. You are being directly going on the YouTube video.
okay.
So this will be for a consistent viewing. So
Okay.
don't go by the questions. You have to continue with the moderation.
Okay, right. If There is no chat box. I can see any chatting or questions. What to do? To conclude,
No, maybe you can raise some relevant questions which we can interact actually.
okay.
So Dr. Vishal has raised a wonderful point that definitely surgical results and intervention results have become very secure nowadays. But are there subsets of patients where we would still like to have a guarded prognosis? Are there any subsets of patients, Dr. Vishal?
Yeah, so that's what I have mentioned. Children with chronic dilated cardiomyopathies, children with single ventricular hearts, they have not so good prognosis. However, still there are options like heart transplantation, heart lung transplantation. But yes, 10 to 15% of the children with overall CHDs and majority of this scenarios which I have mentioned have a little bit guarded prognosis. However, single ventricle child also, if timely managed, their quality of life and longevity of life is better as compared to non-treating them.
So your take on hypoplastic left heart syndrome. What is your take as Indian scenario and maybe a scenario world over?
I would, so again, it falls into category of single ventricular heart. So HLHS, I would defer for any intervention and allow them just a supportive care without doing anything. It carries a very bad prognosis. Even surgical mortality is more than 50%.
Dr. Prabhat, your take on about say a
Dr.
common what should be the counseling for a common CHD once who has been operated and has come for a follow-up? As a pediatrician, when I would be sending for a review echo or a follow-up echo?
Usually they found on examination having some murmur, residual murmurs. They see the child is not growing properly or some other reason. They send for the review. Usually they don't send for review for the CSG repair. They review for refer for the some other regions most of times.
So now the question is, suppose as a pediatrician, because all the audience are pediatrician, and this has been recorded and is going to play live repeatedly to pediatrics. So we have to raise a relevant question. So suppose the child has been treated for surgery or intervention. As a pediatrician, when I should be sending for to back to pediatric cardiologist for a review, or I can keep under follow-up under my care. As a pediatrician, what should be my guideline for a follow-up?
So to keep in follow up regularly, if there is some residual problems or there is advice by the pediatric cardiologist, and if they have not advised proper that is regular follow up, so they follow for the other regions also, like arrhythmia or something noticed during the follow up.
Okay, so maybe surgical discharge summary is very important guideline. And whenever you get a patient, it's always good idea to discuss with the primary pediatric cardiologist. Dr. Vishal, your take on this with office practice as to how do you advise for a follow-up of any child who has underwent an intervention or a surgery?
So if I'm a pediatrician or if I'm a pediatric cardiologist?
If I'm a pediatrician, your take for a pediatrician, because all our audience are pediatricians.
Okay. So children who underwent corrective cardiac intervention or cardiac surgery, they require follow-up first year after the procedure or surgery, 2 to 3 follow-ups with a pediatric cardiologist. then once in a year for 1 or 2 follow-ups, then every 2 to 3 years till child goes to college. However, guideline says that they should undergo lifelong follow-up. Now, if we look at they become adult, right? Now, let us talk about adult preventive cardiac care guidelines. Nowadays, looking at all these events happening and all, every adult should undergo annual cardiac checkup, but if not annual, once in 5 years. So initially, because of they underwent some cardiac intervention during childhood, we follow up them till adults, and once they go to college, ideally they should undergo, like anybody should undergo adult preventive cardiac care guideline once in 5-year checkup. And as far as those with palliative procedure or those with still some residual lesions, annual cardiac checkup till final wordings by a pediatric cardiologist. So there is a wide range of follow-up advices we see in pediatricians prescription. Usually many of them do not come for follow-up because they are completely normal, they are cured. But sometimes rare onset of arrhythmias or certain other issues like child who has undergone VSD closure and RVOT resection, and child has minimal small muscle bundle which is not causing any problem at this point of time, but may develop recurrence of RVOT obstruction. So pediatricians look after children till they become adults. So till the person is adult, at least that pediatrician should keep under follow.
So, Dr. Bhatt, any other relevant question which you feel should, from this presentation, which should appeal the pediatrician? Actually, you can actually raise it amongst ourselves. Remember, this talk is getting recorded and is going live and is being replayed for pediatric PGs, for pediatricians across India. So we have to think in terms of what a pediatrician question would be. It will not appear on chat box because
Okay.
on Zoom we are only 4 people here.
Yes.
But it is being zoomed live on YouTube.
For them, sir, it's not the pediatric cardiology means only echocardiography. If you are sending a patient for some evaluation, don't write only echocardiography because we have to take some other tests. Sometimes patients refuse for going for the extra tests. They don't give relevant histories. So I think cardiology, pediatric cardiology, that means only echocardiography. They should write down some history, brief histories, and it's up to on the pediatric cardiologist. They will decide what to do further. Most of the time, I see they refer for only the echocardiography, not for consultation. If I find out something major problems, they refuse to consult us. So I think it should be given to pediatric cardiologist. You should counsel him what to do, when to do, and how to do so.
Yes. Dr. Vishal, your last few words, which pediatrician, Dr. Prabhat said, the echocardiography is just part of the whole clinical evaluation of a pediatric cardiology patient, which includes a very good clinical examination, echocardiography, and then echocardiography is just part of it. The diagnosis actually comes from the whole clinical examination. Just for simple reason that the patient may have high echocardiography may show high right-sided pressures. High right-sided pressures could also mean the lung pressures are high, pulmonary artery hypertension. But right-sided pressure high may also mean that there is a peripheral pulmonary stenosis. That means the peripheral pulmonary arteries are narrow. So it is important that one auscultates the chest. If the chest has a murmur, definitely we are dealing with peripheral PS, not with the PAH. So this is one of the examples. That means to say clinical and stethoscope is equally important than a cardiac examination, as Dr. Prabhat has raised. Dr. Vishal, your take on a referral by a pediatrician any way a referral can be made more informative for a pediatric cardiologist?
Okay, so still we see many prescriptions of pediatrician mentioning ECHO, echo, that's it. But as I have detailed description, I have had detailed analysis and discussion on bedside clinical diagnosis. I have always, stressed upon to my fellow pediatricians also. And in today's talk, as I have mentioned, that it is good idea to classify them for a bedside diagnosis like acyanotic congenital heart disease with small shunt lesion, probably small shunt lesion, no cardiac symptoms. And such kind of bedside diagnosis will help pediatrician also to write the further treatment plan, even if echo report is not available. And as far as counseling is concerned, I have already discussed what to be counseled to family member while ordering echocardiogram. And we can always talk to a pediatric cardiologist in front of patient if time permits. It has got two advantages. Number one, it gives it gives a kind of faith building between patient and a referring pediatric cardiologist, and it shows a concern of a treating pediatrician that yes, I do care about your child's heart, and let us do the best together. So these are certain points apart from the points which I have already mentioned.
So I think Dr. Vishal has beautifully summarized that the discussion and communication is very important when sending a patient to a pediatric cardiologist, because many a times pediatrician who is following up will give a very good information, and also this helps in a rapport building between the team, because the team consists of a pediatrician, the pediatric cardiologist, and together as a team we treat the heart of the patient. Dr. Prabhat, maybe you can summarize and actually wind up this session.
Thank you so much,
Now that
Dr. Neeraj sir. You are the coordinator for this event. And thank you so much, Dr. Vishal sir, having the wonderful presentation. And it's very useful for the pediatrician who see the patient in OPD, in IPD. And sometimes they miss if they are busy in OPD, or even miss sometimes the diagnosis. So they take help from us and ask for the echocardiography and further. And I see in the particularly in the developing state like in Bihar, so day by day the scope of pediatric cardiology is growing up, and more and more pediatricians are asking for the echocardiography and asking for help. So very good thing. And thank you so much, sir. So again, Pravina sir, you are organizing these kind of events. It will be the helpful for the pediatrician. Thank you so much.
Thank you, Dr. Vishal. Dr. Vishal, who is having a busy pediatric cardiology practice, and Dr. Prabhat, who is actually the busiest pediatric cardiologist in Bihar, with I understand has taken a valuable time to contribute to this particular discussion. With this, I would like to also conclude and give information that first Saturday of every month we are organizing this evening activity with dinner. So all the pediatricians in the country who are actually joined with us today and who will be actually going through this central IAP platform, viewing this particular presentation, it is a request that please be in touch on the first Saturday of every month, have dinner with us online, and maybe if your child has a heart, it is a good idea that you become member of the Pediatric Cardiology IAP chapter. Pediatric Cardiology IAP chapter invites all the pediatricians,
Very good.
those who are treating any kids, and if their kids have a heart, please be a member of Pediatric Cardiology IAP chapter. Feel free to actually interact with the team of Pediatric Cardiology IAP chapter. We have a chapter website online, or you can contact us on personal numbers, the Pediatric IAP platform, and we will be happy to assist for having this membership in Pediatric Cardiology IAP chapter. Already a newsletter has been published, which is a regular publication, and which will be the second newsletter is now out, and there will be a regular circulation of newsletter of Pediatric Cardiology chapter, which will be there from the chapter, and there will be multitude of activities which are already lined up. So looking forward for all your contributions and support, and feel free to put in any particular topic you feel we should be raising through this platform. Thank you. At the end, Dr. Vishal, you.
Dr. Neeraj sir, is there any planning for making the state branch from pediatric cardiology?
Yes, there was in the in the recent work which we had central meeting, it was decided that there will be a regional workshops. If somebody can take this task regionally, each state can organize the IAP pediatric cardiology workshop with the pediatric cardiology chapter, which we will looking for. There will be a core. There are multiple of core committees which are being formed. One of this is a state committee. That means you organize the IAP cardiology chapter workshop in your place, and we will be happy to be part of it. And of course, one is the advocacy platform, where we are going to go to the government and go and drive in certain activities and certain concerns by the pediatric cardiologist. Third is, of course, the coordination committee, which is going to coordinate. Remember, there is a Pediatric Cardiac Society of India, which is a very good body, and we are not saying Pediatric Cardiology IAP chapter is a separate chapter. We are saying we have to work together. So PCSI IAP coordination has to come. So this is thing which we are actually, and there are few other activities which has been planned for medical college concern. So all these core committees have been formed. At this platform, I would actually invite that if somebody can take the initiative of zonal organization, it will be very, very good. Please feel free from your state that I want to do it, and we will be happy to be part of the whole program.
Right. Very good, sir.
So next Saturday, first Saturday, we'll be announcing soon. Dr. Pramod Ambadkar will be actually from Nagpur, will be presenting the thing with the appropriate moderator, which will be sharing the program soon. Thank you all. Thank you, Vishal. Thank you, Dr. Prabhat, for this. Thank you.
Yeah, thank you, Dr. Prabhat and Dr. Neeraj, for the excellent.
Thank you, Vishal. Thank you. Good night.
Bye.
Thank you.